Okay, great. We'll go ahead and get started. Thank you everybody for joining us for the webinar today on the new advanced primary care model that Medicare has just approved as of November 1st. And that is to take effect next year for options for different payment models and care management. And we're really excited to have everybody here today to join me on this talk that we'll guide through. For those who don't know, I'm Paul Huffman, the Chief Revenue Officer at MD Revolution. I have been here since 2019, but I've been working in this care management space since some of these codes were first approved in 2015. So I've seen how these have evolved and changed over the years, and we're really excited about these new codes for next year. With me today, I have my colleague, Michael Moore, our Chief Product Officer, who is in charge of the development of the platform and how we use it with our care teams and deliver care, but also how some of our other customers use it as well. And then we're very fortunate to have one of the chief medical officer from one of our analytics partners, ReportingMD. Dr. Larry Bosser from ReportingMD has been working as a primary care physician for almost 40 years. And ReportingMD has been in this value-based analytics space for over 20 years. So we are fortunate to have them as a partner and to start this discussion and to chime in. So with that, Dr. Blosser has not only been or is the chief medical officer at ReportingMD, but like I had mentioned, also was a practicing physician for over 40 years. And in those roles, he has seen this firsthand as either the corporate medical director and then chief medical officer at Central Ohio Primary Care, but also served as the system primary care clinical operations chair for Ohio Health. So in those different roles, he has seen firsthand how these value-based programs work, how analytics can help power those, and then how you can then direct your interventions and care management to the patients that need it, and to direct that care for what they need, which is why we think some of these codes are important. And so to lead that off, this whole talk is, what is this opportunity, right? What are we getting into starting next year? And then also, where do we think it's headed, right? So these are going to constantly evolve. And so we need to be ready for those evolutions and changes and how that affects the care that we're delivering in between office visits and coordinating for the patients. So I'm going to kick this off to Dr. Blosser and ask him, what is your vision in all of this, and where do you think we're headed? And then we'll get into the outline and kind of the meat and potatoes of what we're going to talk about today. Dr. Blosser?
Sure. I think the chronic care management is a step towards value-based care. And I think where healthcare in this country is headed is we need to provide better cost of care for the people that we care for. So I think chronic care management fits directly into that because it really improves patient outcomes. And that's a patient satisfier, that's a provider satisfier. So I think we are headed towards a different payment structure ultimately for healthcare. And I think this is one way to get started on that.
Great. And that's what we're excited about, is where you can have specific attributions for certain patient populations and deliver care where it's needed, which is what we'll talk about today. So just reviewing the outline and what we're going to be discussing here for the next hour, we do want to hit exactly what are these codes, how we got here in the history of different payment models and some pilots that Medicare has done in the past, and then what is the overall purpose and where we think it's headed, and definitions of those codes, the different payment levels for different patient types and different attributions. And then what are not only the care delivery requirements in these codes, but there's a really important analytics portion as well. So what are those data requirements? How do we segment patients and deliver specific care to where it's needed in a world where now those interventions aren't going to be time-based necessarily. It'll be based on what you're doing and how you're doing it and to what patients. So that's really, really important. And I think that the question that's on a lot of people's mind, like, what is the fit for your practice, for your health system, for your organization? should we go this APCM route, or should we right now stay in traditional CCM? And we'll touch on that a little bit, and we have opinions on who this immediately might be a good fit for, and then possibly just be ready for it, right? So as these evolve, make sure that you're prepared if the switch is right for you, or if there are changes to the codes in subsequent years. And then we will have about a 15 minutes for questions and answers as well. I'd like to add, we are recording this talk also, so we will be sending out a link if you want to forward it on to anyone in your organization and review it at a later date. So how did we get here? What is the overall vision? But I think it's important to touch on how we got to this point, right? And CMS has already communicated that they want to develop a program that not only supports primary care financially for work being performed, but and care coordination in general, but we want the patients, the primary point of contact, to not only be the person coordinated in their care, but we want that to be more personalized for those patient types, and have the payment be different for those different attributes, which is a little bit different than traditional kind of broad stroke CCM on whoever got the most attention each month is kind of where the payment went. And so now it is really more focused on the actual interventions and the patients that need it. So we got here from just different models, right? So there was CCM 2015, really implemented in 2016. Then we tried the CPC Plus model, which gave some attributes to patients, but also was more of a per patient per month spend by Medicare. And after that, we now have models like Primary Care First, ACO REACH, which is a direct Medicare program that started last year and piloted last year, and then traditional MIPS and MACRA and all those value-based programs that might seem more familiar, and reporting. Dr. Blosser will talk about a little bit about that, like what they've done in that space and how that correlates with these new codes. And so now we're really tying all this though to patient attribution, not only population health analytics, but care management analytics. How does that tie to interventions, and what do you do with that data? And then if you are in an ACO REACH program, or if you are in a value-based program, how does all of this correlate to a value-based model and payment system? So how are we allocating those funds and spend to correlate more with your overall value-based goals? So what is this model, and how does it fit in overall care management and from a clinical side? So this is the first time in care management that there's a specific program that is not time-based. So it is care delivery based on the patient's attributes, their risk, and their need. And this is similar to how we've always done CCM in general. We do have time codes, and we are timing the times. Right, we have the evidence of time with the patient in all of our documentation, but now it's more based on the interventions and what is completed, and not based that time. So we want to bring all the pieces together for the provider, specific program management. Are there devices in that program? So remote patient monitoring is not affected by these codes. And so you can still deliver additional interventions based on patient's need and based on your goals as an overall practice, but again, not affecting the RPM model or the fee-for-service model currently. And then how do we fit in analytics in that picture, right? How do we take that analytics and guide care coordination, and then deliver it to the patient? And then it's that constant feedback loop back to the provider. And again, the overall goal is to reduce spend, right? So Medicare wants to see if these new models are more related or can have a correlation to reduce spending.
Hey, Paul, if I can chime in there, I think that it's a really important point. When we looked at these codes as an organization, we felt it was a really great step forward, because a one-size-fits-all approach to everyone needs time, and the only time that is really compensated for is human time doing specific steps. What is not necessarily what we think is the best way to really get these services out to everyone. But by reducing the reliance solely on individual individual clinician time, that also opens up the investment opportunity around analytics. But also, as an organization, we've always had put investment into technology and patient services that weren't actually compensated as part of the time for CCM. So patient engagement tools, direct texting, support, some content, and some wraparound things that we felt were a better way to get patient engagement and thereby adherence. But really, in the traditional codes, if there weren't a human looking at it for that time, it was just really on us to figure out how to invest in those things. And now I think it really opens up all of those channels of communication and a great opportunity. And so I'll talk a little bit more specifically on some of those. But I think this is, one, a reduction in time, but two, an understanding that there's a series of investments that really go into doing this right.
Yeah, I think that's a good point, right? Traditional CCM does not compensate for efficiencies, right? It compensates for time and work, and we feel this is now a shift towards efficiency and interventions as opposed to time spent. So what are these levels? There are 3 different levels that are in this rule and in the codes. I'll just factually go over each one of those attributes and different patient levels that Medicare has defined as eligible for each one. So the lowest level, or the least amount of need, the way that Medicare is defining it right now, are patients with, as they say, 1 to less chronic conditions. So any Medicare patient that is tied to the practice and has consented to be in this program now has access for these services. It's not certain requirements for outreach and time, but having access to the tools that Michael's going to talk about, right? Care coordination, access to the provider, clinical access, but also this continuity of care that can be delivered a lot of times through technology and not necessarily a care management call every month. That same level, or that second level, I'm sorry, is one that could be most related, I think, to the traditional CPT 99490. So patients with 2 or more chronic conditions that are going to last at least 12 months. All right, almost the same definition as a CCM eligible patient, but again, no time requirements necessary. And then the highest level, or the highest reimbursement rather, are patients that are considered qualified Medicare beneficiaries with 2 or more chronic conditions. And I think it gets missed sometimes what that definition means. Sometimes called a QMB patient. It means a patient that is considering a lower income Medicare beneficiary that is dual eligible for Medicare and Medicaid, and that Medicaid portion covering deductibles, co-pays, any co-insurance that's necessary for services, is the definition by Medicare for that. And those have been deemed by Medicare as getting the highest reimbursement when they consent to these programs. I'm going to turn it over to my colleague Michael to talk. Like I said, we see two layers to this, and one is the care delivery and the care program itself, but then the analytics portion. So Michael, if you want to take it away, I'll hand it over to you.
Great, thanks, Paul. So I want to spend a few minutes talking about what this means as APCM comes. They've identified the various components that should be available for all patients, and that practices have the capability to be able to deliver. It's important, as we note, these are obviously regulation changes. It's really, there are components of care that I'll be talking about, but this is also really changes for many practices in just how they deliver care and philosophy. So, we are really here to help practices look at readiness on this and a path to, working towards the goal. And I think as Larry will talk even further, beyond what this 2025's regulation goals are, but really what Medicare is saying around the direction of all of these. So this will be an evolution. So fortunately, unlike some years, there's nothing that's forced to happen to everyone on January 1. We don't always get the luxury of being able to choose in that time frame. So in the spirit of trying to really understand those components, many of these are things that have existed in care programs and were parts of either care management or CPC Plus and other things. So there really are 13 items, and we have a resource center available online that has a lot of detail around each of these individual items. But there are really 10 items that have some very clear overlap with traditional chronic care management or remote patient monitoring programs, but have really even more incentive to double down on making these things available for a patient. But a lot of correlation, similar patient consent processes, same initiation visit being required for patients who may not have been seen recently. And that is really just making sure that kind of ownership and the longitudinal care that's going to be part of this is really driven by that primary care physician and the care that the practice is coordinating. Things around 24/7 access is similar to the traditional codes, but even more specificity around what that means on types of services and escalations and clinical access, off hours as part of really what they're saying and just overall alternative care delivery models. And then really looking at continuity of care. And that comes down to, making sure that, really catching and being there and supporting a patient in handoff between providers. And so what I really love most about these is, as we look at care management, is I think this is really saying that the whole experience and the care world for that patient should focus around that one primary care physician and the resources that they make available as needed. And the gaps where people can fall off going between specialists and back to the primary care, or if they had a hospital visit and things like that. This is really saying we want to make sure that people are, number one, have these services available, but are truly supported through all those transitions. Other things that are very consistent is, care plan creation. I mentioned the transition of care, but really making sure that, there are means of communication available for the patient, really meeting them where they're at. So that is great for electronic and alternate communications, texting, app secure communication, but also making sure that there's ongoing communication with caregivers and other people that may be involved in the patient's care. Along with those, and where we're most excited, because we think this is, where all of the great opportunities come for benefits at a patient outcome level, but now really tying all of these services to population data analytics, risk stratification, and really aligning and getting performance measurements in place. Even though those performance measurements aren't kind of any requirements around those individual items, it really is maturing the way that all these programs can be looked at. How's the best utilization of services? What's making the highest impact for the patient, and how that can influence the care that they're receiving. And so that'll be, I won't jump into Larry's section at all, but, this is where, these are new to these primary care focused programs in many cases, but certainly not new in terms of, where these methodologies and practices come in. What we think is really important is now being able to tie that not only to an annual event or ongoing reporting, but really working day to day to influence the care that's being delivered to the patient and how patients are being managed within the program. When we first looked at these, so we have referred to our care program engine, which is really the way our platform works today to deliver care management programs. And those are, most commonly, that's chronic care management and remote patient monitoring. But we also have transitional care management. We have patient engagement programs that are built around remote patient monitoring, individual health specialties and practice specifications. A lot of assessment-driven programs around nutrition and different items. So to us, the first thing we really did was take a look at of these program changes, which of those have coverage today and what we do in our clinical services or what our platform supports. And so on the left side, you really see all the things that we do today in any one of the different programs that we offer. And so we're really fortunate as a task-based system that changing the recipe is an easy step for us. So we can now look at practices and even help plan out how to meet those items that were on the previous slide with existing workflows, patient engagement activities, and care coordination items we do today to really build the best of for covering all of the required components of this. What I think is also really excited, and I alluded to earlier, is what this means for being able to invest in alternative ways of interacting and engaging the patient. So things are around, more automation, maybe AI models to support ongoing nudges, content recommendations, and interactions with the patient that help keep their health activities and the commitments that they've made on tracking items and participating in their care plan front and center. It also means that investment in AI models to help automate things that technology can do as well or better than maybe the clinicians can, allow us to really use the clinical resources then at those high value, high touch points that will be dictated by the care plan, but also now by either the risk level of the patient or an emerging risk or an emerging care gap. And then just simple things like AI, agents that can auto-respond to make sure that they get more complete answers anytime, really meeting the patient where they're at the point that they have these questions. And then, really beginning to expand out a library of all the community support coordination and resources and, being able to do that along with the practice to plan comprehensive coverage in those areas, but really a seamless patient experience that allows remote teams to be able to support the practice as best they can in a really connected way. And so, as we kind of look at these things, what we know is that having it be connected and having that analytics be real-time influence of care is going to be really critical. And the last thing I'll show, and this is just to help set up a transition over to Larry, is how this really means as a kind of workflow for the patient. So starting at the point of initiating this program after the evaluation has been done of if this program is right for a practice. When we kick off, the life cycle for a patient and the practice is really to first, initiate the analytics activities, get that data in, and understand how that's going to influence kind of all patients and particular patients by giving us a sense of risk and where to focus, but also who's eligible, who to reach, how to explain the benefits, and really begin to align care and get patients engaged. That analytics will really set the basis for, along with their diagnosis and other recommendations from the provider, a comprehensive care plan that's going to have, goals for them, might indicate the use of remote patient monitoring in addition to the APCM program, but really set a course for the patient. But what I think is most important then, as that care is being delivered, now each month's care may be dictated by a cadence based on risk or care gaps that are known, but also can be immediately adapted based on new or even resolved care gaps that now don't need attention, and there's another next high priority item to address. So I think the continuous feed of this is really creating an exciting point where, analysis is not only a point in time exercise, but part of a living and breathing care program that's responding in real time to take those insights, turn them into actions, and be able to even measure then the effects of all those actions. So with that, I will.
Well, Mike, before you go on, I wanted to ask you.
Yeah.
So, you didn't gloss over it, but I think that's an important point. Like when we're looking at traditional CCM, we definitely personalize people based on their diagnosis codes. But when you're talking about specific interventions, can you just describe from a stratification or analytics portion, taking those, lack of a better term, gaps in care or initiatives,
Sure.
how would that work then in the care delivery model and some of the automation designs? How do we then pinpoint interventions for that make it more specific for patients' needs and then overall hopefully reduce the spend?
Yeah, and that's a great question. So when we planned that out from really the kind of patient's care path and overall for a program for a practice, there's going to be timed activities and a level of care. So really simply put, who's kind of high touch, who's low touch as a starting point. So the care planning would be the same. We'd identify diagnosis, and those all have activities, content, assessments, and things built in around that. When we go into, say, the second month of care or the third month of care, now there's a lot of considerations that's going to decide, is someone high touch, low touch, and are we going along with planned, or are we responding to new and emerging data that's telling us our plans should change? So let's say it's not a high risk patient. We can put them on a path of some self-report or get them connected with a remote patient monitoring device and really have activities that are planned, content that's automated, and engagement that's going on without kind of human interaction, but really driven off of that care plan. If at the same time we're doing an update to analytics and that's saying, hey, we just identified, a patient has, now is out of date for a certain cancer screening, that has pathways that are identified in our platform that take that emerging care gap and translate it to a task, set a priority on it, and it can either, make that outreach more immediate. So we move that to this month, even though we had not planned, or can take an already planned intervention point and immediately change it to a higher priority item. And so we do this today in our existing care path. Everyone gets the same calls. We are, I refer to them as interrupting tasks. So something becomes more important or more urgent for the patient or from a analytics perspective. And so it really is just adapting in real time, always saying, hey, what's the best use of our clinical team that's doing the outreach so that we can do that? And also, what's the best way that we can support the practice by lining up the next visit and helping the patient and understanding maybe any others. It may not just be knowledge of the need for that screening, but it may be transportation back to the practice for that screening. So we're able to reach out and understand both kind of behaviorally if there's anything that's getting in the way, as well as, making sure we're informing them. So it's really, we would say truly dynamic care in that, we have a plan that's set by the care path, but we adapt in real time based on what we know or what's emerged for the patient.
Great, thank you. And I will hand it over to Dr. Blosser to go into more of the analytics portion. I do want to mention that we are getting a lot of really good questions, and we're going to make sure to have time to answer all of those because all the ones that have came in so far are really, really good questions. Dr. Blosser?
Thanks, Paul. We at ReportingMD are really excited to work with MD Revolution to provide data analytics to help everybody succeed in advanced primary care. I am a primary care physician, family physician, as Paul mentioned, for 40 years, but I did want to tell you that I started when I'm 10, so I'm not that old, really. But, to be successful in advanced primary care, you really are going to need a robust analytics capability. We know, and you've heard already, that data drives decisions, and data will change care pathways and plans for patients. So it's important that you have real-time, up-to-date data to make those decisions. And any data analytics platform that you would use needs to have a number of capabilities. They need to be able to ingest data from multiple sources. They need to be able to normalize and validate that data. And then they need to be able to create a rich data asset from that. What you see on this slide is how we do that at ReportingMD. And as Paul mentioned, we've been doing this for over 20 years in lots of different programs. But we're able to bring data in through multiple different data sources, disparate sources, different EHRs, different data types, claims data, those kinds of things. And we bring that into our clinical data warehouse. And there we go through a validation process. And we use some specific algorithms to make sure that we tie data to the specific patient that it's supposed to be tied to. And we have a high reliability on making sure that the data is correct for an individual patient. That data is then moved to what we call our TOM database, our Total Outcomes Management database. And then we utilize the TOM performance analytic capabilities to produce that data set as an output. And we can send that data in any number of different places. You can see on this slide that we will have a bi-directional exchange of information with MD Revolution so that they can take the data and help practices identify patients and build care plans. If APCM goes as expected, ultimately there will need to be some submissions to CMS down the road. And we have the capability, as we're a qualified registry, CMS will recognize ReportingMD and their ability to report the data directly to CMS. Could you move to the next slide, Paul? I think an integrated approach to data analysis is really critical. Having your data analysis right within your MD Revolution platform is really critical. It helps you align your approach between chronic care management and population health and MIPS value pathway efforts. I think the data is really important. When I started years ago thinking about clinical care management, what would happen is I'd walk out of a room and find one of my care team members and say, "Hey, Mrs. Smith in room A, we need to find a diabetes program for her." These days, what we're able to do with data and analytics is to identify all the patients that would qualify for chronic care management. We're able to stratify them based on their risk or their disease burden or their open gaps. And that allows to build an individualized care plan for each individual patient that addresses their needs. That results in better patient outcomes. And, you know, as a primary care doc, I loved anything that would help my patients get a better outcome. But not only that, it also identifies additional patients to enter into care management programs, and that provides some additional CCM revenue. And ultimately, if patient outcomes are better, total cost of care is better, and that produces higher quality scores. So it also may make it that you can see a positive MIPS incentive. So, you know, basically what happens now with data is that we can identify for clinicians and care teams who the patients are that they should be focusing on. And that's one less thing on the care team's plate. They no longer have to think about identifying patients. They just think about, what are we going to do to address these care issues? I think the other thing that I'd say about the advanced primary care management program is, as a primary care physician, the one thing that it does is it allows you to be compensated for patients in a different way than just fee for service, seeing people in the office. Primary care docs do a lot of care that was never compensated, and I see this as a valuable change in the way we view taking care of patients. Robust data analytics will also help you drive the level of care and the actions that you take for individual patients. If you marry clinical data with claims management, it will, or claims analysis, it'll allow you to look for clusters of patients, either by acuity or disease burden or complexity of care, and will help you stratify who might be your first choice of folks to address, who has the most gaps. The analytics will also drive risk stratification, and you can include social determinants of health, things that might get in the way of your care plan, and you can identify those and hopefully navigate around those to make sure that your patient is getting the individualized care plan and that they'll be able to carry it out. The analytics will also help you understand risk adjustment and help you understand who may be in most need of care plans as you look at your total patient population. And it will also help you with individual clinical benchmarking. And there again, that drives individualization of care pathways. If you could flip to the next one, Paul. As we look forward on the advanced primary care management, we know that there will be some reporting likely in the future. And what that is projected to be is that you will have to report on 4 quality measures out of a list of 13 that are shown here. ReportingMD has the ability to calculate all 13 of these measures. We actually have a library of 1,500 different measures that we can deploy for folks. But the data analytics will allow you to look at your quality measures and identify the 4 that you're best performing in, and in that way help you optimize your reporting. You will also be able to attest and prove your interoperability because of the data exchange with the data warehouse. And the analytics can also look at cost. And so you can be cognizant of your cost measures in real time going forward throughout the year and not just hear about where they are at the end of the year. If you could flip to the next one, Paul. And finally, the analytics can drive lots of different views of the data. You can look at it at an enterprise level, all the way down to an individual patient level, and see all of the issues and gaps and needs of a particular patient. So the analytics can help you manage provider to provider variation, which will help you to maximize your quality performance. You can look at variations in performance from different practices or different care sites. You can use the data to stratify utilization by patients or care gaps or risk scores so that you can understand the need of each individual patient. And you can get down and have a very granular look at any one patient to see exactly what their care needs are.
Yeah, that's great. So now we can identify gaps in care like you've always been doing in a MIPS program or a value-based program, and then deliver specific care for the patients that need it, and have that compensation be tied to the attributes of the patient, not necessarily a time-based code.
Exactly.
Great. So the million-dollar question, Doctor, is how does one measure fit for their organization? The way that you've seen it, you've seen the evolution of all these programs from CPC Plus to MIPS to ACO REACH. A primary care practice, small, medium, large, or a health system, how do they determine a good fit for that practice?
Well, I think it requires a lot of work. So that may seem a little daunting, but there needs to be a process in which you assess where you are and what your capabilities are. And you need to understand what you need to do to move to the next level along the care continuum. Some people are already doing chronic care management and they'll be ready to move on to something else. Some groups are not doing anything. So to have a valued partner like MD Revolution to help you with the evaluation, the preparation, and launch of a program of this magnitude is really critical. You could do it on your own, but I'm willing to bet you'd make a lot of missteps along the way. And to have a valued partner who's done it before, I think that's really making the whole process a lot more manageable.
Yeah, I think the summary is, it's not an easy choice, right? The good thing is that these this APCM model you don't need to choose January 1st which route you're going. The way that we understand it is each provider can choose which model they are delivering care for their patients at any point during the year. And I think that's really important to note, that this isn't let's hurry up and figure this out in the next month and a half or so. This is the evaluation time, and then to decide when evaluate the services that you're already providing. What kind of model are you in from a payment model, and then what analytics do you already have or working with? If none, then let's talk about that and see how we can provide or help with those analytical needs. And then it's a financial outlook, right? It's a pro forma of traditional CCM versus these new models, but then you also have to take into account those value-based kind of initiatives, right? So if you're identifying all these gaps in care, well, now you have a pathway to allocate spend towards the patients that need it most, right? So you may have shied away from doing traditional broad stroke CCM because of some of the contracts you have with certain payers or maybe an ACO. And so that's also what we're excited about is opening it up to maybe some organizations that have shied away from doing traditional CCM. And then it's really about preparing, right? Reviewing the action plans, making sure that we have good care plans in place and initiatives and protocols while we're getting that analytics for each patient. And then it's a lot of times it's going to be transitioning, right? Transitioning maybe from traditional CCM to this APCM model when you're right, or starting up any programs that maybe you had pushed off or had a very focused approach to for certain patients. This should allow you to broaden that reach for care management in general. And then what additional patients do we need to add to those programs? And then that ongoing feedback loop. So it's a lot to think about from the care delivery side, but also from the analytics portion. And that's why we wanted to bring everyone here together to talk about both, because we feel like that analytics portion identifying is a very important piece of all of this. And in order to do it correctly and to do it effectively for patients. That being said, thank you everybody for joining. We do have a few minutes left. We're almost right on time. We got 17 minutes left for some question and answers, and I'll assign those how we got them in order to either myself, Michael, or Dr. Blosser. So starting from the bat, there was a couple questions on how this affects MIPS. We kind of touched upon that, but this is a different program than MIPS, and it could be an additive program to your current MIPS program. Identifying those gaps in care, what are your initiatives and bonuses and some of the value pathways that Dr. Blosser brought up, and then how does that then translate to interventions and care management? So it should affect it in a positive way when done correctly, and then again allocating that spend appropriately. These codes themselves do not need to be billed with an office code. These are billed like regular CCM codes, billed once a month and separately. So even though they are G codes, which G codes traditionally need a modifier to be billed, that's not the case with these. They are G codes that are being tested for 2025 and are billed separately Based on what we have read so far in the final rule, that they will be billed at the start of the month, not the end of the month, which is a big change versus CCM. And each provider will be able to choose how they want to work and then bill for each of their patients, and tied to that NPI. We thought it was going to be practice specific. It looks like right now they've made it provider specific. So your patients, how you want to deliver the care and what codes you want to bill are going to be a provider choice. Each provider is not going to be able to do both, or do APCM every month, and then if there are minutes, bill CCM. So it will be choosing which route to bill these codes. And there was a question about mental health and interventions. It wasn't specifically called out, but the way that we see it is mental health interventions are assessments are continuous based on need, and identifying, again, interventions that might be necessary. They don't necessarily affect separate BHI codes, but we truly believe you can intertwine these assessments for BHI, and certain needs are part of care delivery and management. The difference is now, it's not minute-based. We can send them digitally. We can do them over the phone. It's more about completing the assessments and what you do with that information, as opposed to that time spent with the patient. And I'm just rattling off the list here. I went to anybody else because I know most of these answers, I think. But right now, these are Medicare only codes. Most, if not all, Medicare Advantage plans have to follow the Medicare fee schedule and codes unless they are providing those services themselves. And so we all know out there that Advantage plans or maybe the groups inside the ACO are providing these services. So an Advantage plan, if they can prove to Medicare, just like normal CCM, that they are providing these services, they could be a carve out or a denial for coverage if it's being provided. Now, we can all debate on how well it's being provided or the services that are being provided from those organizations, but we believe that it's going to fall in line just as traditional CCM 99490 codes are today. And then the kind of the $1 million question I was bringing up was, if you are in a value-based program, this ties to it, right? Yes, this will add to your spend just like every other service. If you're on a full risk program, by Medicare, and however that's defined, obviously these codes add to your spend. So that has made some organizations shy away from CCM because of that, because it was a broad stroke, or it is a broad stroke in some instances. And a lot of times we really want to have interventions matched to patients' needs. And that has always been the way that we've delivered care. And so the theory in these codes now is that is aligning more. It's not about the time spent. It's about the need and what did you do for the patient. So yes, it's going to add to your spend when you are in that type of model. But the hope is as we're evaluating, that the spend is allocated to get a return on that spend from a value-based perspective. And Dr. Blosser, you may have more to add on that.
Yeah, I was going to jump in there. So, to the extent that you can utilize the information in these care plans to really optimize patient care, you can reduce the total cost of care. So this may be spending a little bit to get a large return on your investment. It kind of depends how heavily invested you are in care management already. But if you're not very invested, the spend might be very small compared to the potential upside.
Good point. I did have a slide that we weren't going to go over necessarily, but based on the questions that I've received, when you're looking at practice fit, it's really important to note that the spend or the fee for service portion does not affect remote patient monitoring. We didn't really touch on that much. Our remote patient monitoring is still separately reimbursed, still separate qualifications, but is a good add-on to these programs based on the intervention needs of the patient, right? And so going along those lines, billing this code would not get you then a denial for remote patient monitoring. You would be reimbursed for both in the same month. When we look at, just for an example, a pro forma of a group that has maybe 5,000 eligible lives. That's what this is showing right now. The reimbursement of CCM plus RPM, obviously, there's an additive effect when you're adding additional services for the patient, and it allocating, some patients are in CCM and RPM, some are billable every month, some are billable, sometimes CCM only is billable, sometimes RPM is billable. So that takes this into account. We feel like the reimbursement overall is going to be larger for a group that goes to these models plus RPM than going just traditional CCM and RPM. And the reason for that is we're estimating a 20-40-20 rule, 20% of patients being in that first tranche of attributes, and then the majority of the patients being in the middle, but again, a higher reimbursement for dual eligibles. And with all of that, again, not being time-based, we think more patients are going to be eligible in general each month and more consistently in this program. It's going to be more meaningful for patients, more meaningful for providers, but also not based on, again, not just time spent. Your efficiencies are taken into account, and as long as you can prove those interventions and what was done for the patient. Michael, anything to add on that, just from a care delivery standpoint?
No, I think that's exactly it. I mean, those programs can all be used together and used with analytics. So it's there's a lot of variability that's built into that. And so I think having a system and a program that's kind of counting for the right services for each patient and letting analytics drive some of that is going to be really helpful.
Great. We are butting up on time, and there are a lot of questions.
Yeah.
Go ahead.
I will do it again, and I think they posted the link. So one of the things is we have built out a APCM resource center on our website that really is, as we're finding information from Medicare or even from other sources, to be able to share that. So we just posted the link again. We can also, it does seem like a lot of very specific kind of code related and billing related items. We can update the answers there or be reaching out directly with people on some of those answers, because there's a lot of nuance and a few changes around concurrency of services and a few things that changed in between the recommendation and the final rules that are really important points to know. So we're kind of committed to helping everyone be educated, as well as obviously offering what we do and where we can help. But we put a lot of energy into making sure there was a good resource everybody could connect to and watch for regular updates.
Yeah, and I think a general theme in a lot of the questions are, what do we need to do to build this, and is payment based on, what is payment based on, right? There really are no outreach requirements. There's no, like I said, the time-based codes are not, they're gone in this model, but we feel outreach is necessary when it's necessary, right? And so for a patient that needs that, and that comes from those gaps in care, that comes from that analytics portion, right? The analytics portion necessarily isn't what's required to just build these codes, but to be effective and to be meaningful for everyone involved, including Medicare, it needs to be, those interventions need to happen as needed, and define how did you identify those needs, and then what did you do? And so that's really how we've always kind of defined care management. What is needed, and why, what was done, and what was the results. And we're now in that world of providing not only that type of care, but that information back to Medicare. So that's the essence of the codes. I think there's a lot of details we'll all figure out after January 1st and after we start implementing this. But we were built for this type of system and process. And are we ready today to execute it? No, but we do need partners that want to execute it. And it isn't a huge lift from us from a care delivery standpoint, because this is how we've always been built. So I encourage everyone to go to, there is a form you can fill out to do a one-on-one and see if there is a good fit. Like I said, we've modeled it out based on your needs, but also your patient population as well, if you have all that information. Another important measure could be the EMR that you're using, because we feel like all of this is tied back to being integrated with the EMR and providing information back to the providers. So that constant feedback loop is also really, really important. And then if you're already in I've probably repeated this 20 times, if you're already in a value-based payment model or a non-traditional payment model, I should say, this is where we think this is a great opportunity to mold the program to fit whatever your goals are or needs are for those requirements. All right. I think that is all from us. We want to make sure that we respond to anyone's questions. I will get the list and we'll individually respond if we have your contact info. And then also, if you want to have a quick conversation, by all means, reach out to us, and we will also direct your questions to the appropriate person and make sure that any conversations or answers are by the right people. Thank you all.